All right. Hi, everyone. And thank you for taking a listen to SSAT Mentor of the Month podcast. This month, we have Dr. Ajay V. Maker. He is a surgical oncologist and the chief of the UCSF Division of Surgical Oncology. He got his MD at Yale and completed residency at Brigham. He then trained in Surgeonc at the NIH and completed his postdoc studies in tumor immunology at the NCI, including trials that led to the FDA approval of ipilimumab as a new treatment for metastatic melanoma. He later completed a fellowship in surgical oncology at MSK and then gained experience in MIS at the University of Paris. He came to UCSF from his hometown of Chicago, where he was a tenured professor of surgery and of microbiology and immunology at UIC. So his research aims are to improve early detection of pancreatic cancer and develop new therapies for treating metastases. So under grants awarded by the Department of Defense and the NIH, he works on designing novel immunotherapies, particularly for hepatic metastases from colon cancer. So thank you so much for joining us today, Dr. Maker.
Thanks, Connie. It's absolutely a pleasure to be here. Thanks for the invitation.
So first off, in general, thinking about what we want to do with our careers, our focus is to be impactful and creating something meaningful to us and our personal missions. So, those of us who pursue surgery, we pursue medicine to find meaning and purpose, specifically trying to help others with something that's intellectually challenging. So as surgeons, we've chosen a path that requires a significant number of hours to practice and train to refine technical skills, in addition to staying on top of up-to-date surgical indications, management, practice, etc. So obviously you're an incredibly successful surgical scientist and you're an amazing surgeon. These are all take time, take a lot of refining, take a lot of practice. Can you tell us about how you decided to pursue surgical oncology and how you managed to balance all of these things as a surgical scientist?
Sure. Well, thank you for that kind introduction. I think it was a sequence of significant events as to how I chose a career of surgical oncology. Growing up, my father is a general surgeon, surgical oncologist. So from a very early age, I was rounding. I had exposure to seeing the impact that a surgeon could have in the lives of someone with cancer. And I think that made a very profound impact on me at an early time and influential part of my life. When I went to college, I had a great opportunity to work with a gentleman named James Radosevich, who was a PhD at Northwestern. And I worked with him in my summers and my breaks. And he was actually using the first generation of cancer vaccines. What I mean by that is taking a patient's tumors from the OR, digesting them, and then essentially re-injecting them back into the patients. These are the earliest forms of that. And it was a crude, actually it was called a crude digest. And we were just starting to understand how the immune system was working. But that concept of, can we do something surgically and then manipulate it and then give it back to patients in a way that could help them fight their disease was incredibly exciting and novel and intriguing to me. And it opened my eyes to cancer as a potential disease process. In medical school, I then again had another significant exposure to a mentor named Dana Anderson. And he was a very technically adept pancreatic surgeon, but he also ran an RO1 based lab looking at how different hormones were impacting pancreas secretion and also how pancreatic cancer formed from a series of inflammatory events. And through his mentorship and just watching and observing him, I really gained an appreciation, again, for the ability to translate from the bench to bedside and to ask important questions that were translational. And these were around cancer, again, which was very exciting to me. Perhaps, what really sealed the deal was when I went to the NCI during my residency time at the Brigham. And it was there that patients were coming in with metastatic disease to be on clinical trials. Every patient there had to be on a clinical trial, and almost every patient had stage 4 disease. And it was the early days of using adoptive cell transfer, new antibodies, and interleukin-2, which was the only FDA approved cytokine, immunostimulatory cytokine, being used to rev up our immune systems against cancer. And I recall one of our patients, very young woman, she was only in high school, and she had widely metastatic disease. And we treated her with one of these new therapies that really we didn't know how these were going to work, and watched her tumors really melt away. And it was career changing and inspiring to think that we could have this kind of impact on cancer, because our rudimentary understanding of cancer 20 years ago was not very helpful. We don't, and in some ways still don't understand the mechanisms of metastases, how cancer spreads, even how it starts. These are big questions that are still begging answers. But to see that there could be impact on this through a career in surgical oncology was, again, very influential and inspiring to me. And I think that after that, there was no doubt in my mind that that was a direction that I wanted to spend my life and focus efforts.
That was awesome and really inspiring to hear. And especially, as a surgery resident, we take care of patients. And I actually was just, talking with one of our faculty about our colorectal patients, that talking about hepatic metastases and metastectomies. It can be so interesting, the biology of who then has a metastasis after you think you have a complete like a treatment, everything, because they don't have stage 4 cancer at the time, and then eventually after, it's not only like have recurrence but have a metastasis, and it's really like disheartening. But it is really great to hear about stories of people that do have good outcomes, because so often we do see the patients that don't have great outcomes like that, and it is very saddening, but exciting to hear about progress that's being made, and I'm sure it's very exciting for people who are going into research and choosing to go through and do clinical trials. So another question for you is, you've had some very insightful and inspiring comments about mentoring trainees, and we've talked about this on a prior podcast that you've been a part of for SSAT. And can you describe a bit about how you approach mentorship and give some advice for these sort of mentor-mentee pairings? I think a lot of times this can go on a lot of different levels, from medical student to resident, resident to faculty, or, even resident to resident. So there's a lot of different levels of mentorship, and you clearly have had a very successful track doing mentorship across the board. I was curious about your approach and sort of what your thought process is.
Yeah, I appreciate that. Yeah, the mentorship mentee or mentor-mentee relationship is incredibly special, and incredibly strong. It is a relationship that organically can grow, and in the right setting is as strong as a family member. In the feelings that you have for that person, how invested you are in that person's success, and in their failures, and helping them through their career and in their life, right? There's not a great separation between our careers and our lives, and our interests, given how much time and dedication we give to our careers in surgery and in academic surgery. And so I think that relationship's a really beautiful thing. I try to model, I think, some of it on the mentors that I have had, and what energies they put into it, the expectations, the responsibilities. And so I think from the mentor side, it's about giving with no expectation of return. It's about trying to instill the greatest strengths you have into your mentee, but then also guiding them away from your faults, and to be stronger than you are, to steer them in a direction so they don't perhaps go down some of the mistakes you made. It's a great opportunity to pass that forward. From a mentee's side, I think it's just respect for that relationship, in the sense that keeping deadlines, recognizing the time and effort and care that mentors putting into someone, and being receptive, and more than anything, I think communicative. If there is something in that relationship, or in expectations that doesn't align, making sure those are discussed. It really is like a family member, right? You have to have these these sometimes hard conversations in order to keep the strength of that relationship moving forward. And in the right setting, these relationships last decades or a lifetime.
We started this interview talking about Annabelle Fonseca, who's an example of a mentee that you have, and she's here at UAB with us now. How do you sort of keep up these relationships and keep communicating and stay in touch, even as people sort of like move on to different areas? Is it just like through conferences or emails, or how do you just like keep in touch with your mentees?
Sure. Well, she's fantastic. And she's an example of, relationships that are, there's a spectrum of sponsorship, mentorship, a combination of both. And perhaps we can talk about that on another call. But how you keep in touch with people, I think it's a two-way street. It's checking in on occasion and just seeing how people are doing. And then in times when there are needs, such as grant submissions, promotions, job changes, career questions, even family balance questions. This is when you take time and you meet and you do it. Now it's easier to do things, on telemedicine or on the phone, but certainly one of the benefits of these meetings that we have is being able to sit in person. And I think what I enjoy most about going to meetings and having them in person again is being actually able to go and sit down with friends and colleagues and mentees and my mentors and sponsors as well, to keep up those personal relationships.
And we've talked a lot about sort of the things that you've accomplished in your career, and it's all obviously very impressive, but also I'm sure very time consuming. And you talk about sort of the relationship that you have with mentees sort of bleeding into your life and your interests and your career, but also your family. So sort of how do you balance these relationships? Because like you said, like mentees can often feel like part of your family. And I certainly, the mentors that I have here at UAB, I often feel like I'm like their child, like that they're taking care of me like a parent would. But I also know that it's very time consuming on their end as well. So how do you sort of balance not only accomplishing these things in your career, but also taking care of your actual family and your surgical family? It's a lot of people and things to manage at the same time.
It is. And you're bringing up an important point. And I think this is why there's so much of an emphasis recently on these concepts of burnout or satisfaction with one's career. I think everyone has to figure this out for themselves as to what drives them, what makes them happy. I find these relationships actually energizing. Without them, I think it would be very difficult to keep the mission, the tripartite mission, moving forward, because you get that perspective, you get that that human relationship, the edge to it, that drives us. For my own family, I have a very loving wife who is a physician also and is very busy in her career. And I have three awesome little boys, and I want to be the coach of their soccer team and their t-ball team and not miss, a basketball game. And of course that can be challenging, but I find it very invigorating. And so we work around it. We find ways to get that done. Because at the end of the day, if your work life and your home life are not both contributing to your energy and to your happiness, neither of them will be successful. And now, obviously, the world isn't perfect, and not everything is going to be perfectly aligned every day. There has to be give and take. But as much effort has to be put into the home life as is put into the work life. And perhaps that's something I also learned from the previous generation. All the mentors I've mentioned to you were, including my father, were, people that were working 7 days a week. And this job was all encompassing, and yet they found time to give. And so the world has changed, surgery has changed, training has changed since that model, but the passion has not. And so, it is a balance. I don't have a great answer for you. My family will probably tell you I'm not home as much as I think I am, but I think I've done a better job, and we do a lot of communication on what are the most important things to be part of. The other thing I often remember is that it's not so much the quantity of time, it's also the quality of time. And so when you are with, either at work or with your family, that time should be very focused and very concentrated. If it's the dinner table, phones should not be out. We talk to each other face to face. If we're at work, it's not being distracted and surfing the internet when either patient care or a grant or a paper needs to be written. It does require coordinating of time and focus.
I think as a resident trying to balance, a lot of things at the same time, it's kind of scary thinking about as an attending, you only get busier.
That's right.
Being intentional about the time that you spend when you are spending that time is a lesson I think that we all sort of learn as we mature and grow, not only as surgeons, but also as people. And I think it's something that's very difficult for us that are trying to do like multiple things at the same time always. And that was also really interesting insight too, just about keeping your cup full, whether that's the things that you do at work or the things that you do at home, trying to do things that are really creating meaning for you. And the research that you do, I think is like so interesting and life-changing, obviously for the patients, but also for the careers that people can choose to pursue. You had mentioned before at a prior SSAT interview, sort of your approach to mentoring students and trainees that come into your lab, sort of how you engage them in projects and how you advocate for them and try to help contribute to their careers, even moving forward. Can you describe a bit just sort of people that might be like, I might think of myself as a new attending in the next couple of years and trying to make sure I'm doing a good job taking on mentees and guiding them in the right direction and trying to promote them and help them as much as I can. Would appreciate any thoughts you have about the framework that you take towards training those trainees.
We have to think of what's the future of medicine going to be and what do we want the next generation to be able to do that either we didn't learn or they're going to have the opportunity for because it didn't exist when we were doing it. It's to prepare them to be able to embrace those things and take them to the next level. From a cancer perspective, what they're going to be up against is a little different than what we're up against. When we have been asked the question, is this a resectable tumor? It's a pretty straightforward technical question. However, what is technically resectable and what is biologically resectable are now two different things. And the challenge for the surgeon now in surgical oncology is to recognize all of the biology, to understand it, so that something that is technically unresectable may actually become technically resectable, whether if the biology changes from unresectable to resectable. And so that means we need to understand the trials, we need to understand the new technologies that are coming down the pipeline and how to interpret them. There's no doubt, I just got back from the NIH for study section where we were reviewing grants that were proposing drugs that are out on the market or trials that are already being done that have way outpaced the ability of science to study the mechanism of action. Just the pharma and biotech have moved much faster than academia in development of new treatments. And so if we stop and ask ourselves, should we be using these? We have to advise those companies and those firms how to use the drugs they've developed in a proper way. And we have to understand how can we use these to take a either biologically or technically unresectable patient and time the treatments appropriately to allow these patients to then have opportunity for cure or resection that they didn't have before. Now, that's kind of at a 360-degree level. Down at the lower level, it's what does that mean? It means if someone's interested in research, they need to understand metadata at this point. They need to understand what is single-cell RNA-seq, what is circulating tumor DNA, what are exosomes. That doesn't mean one has to be an expert in them or even run the trials in them, but understand how this data and this next generation of tests and evaluations can be used to help us treat our patients. So as a mentor, if we have that knowledge, it's our onus to pass it down. And if we don't, it's to guide them to the directions of where they need to learn. That's on the science side. On the clinical side, obviously there's training into minimally invasive surgery, whether that's laparoscopic, robotic. There's new robots coming out. There's new techniques that are constantly being developed and guiding our our mentees towards what we think are going to be the most influential or the next generation of treatment so that they can keep the field moving forward. It's a wonderful relationship because you often learn as much from them as they're learning from you.
That's awesome. Well, thank you so much, Dr. Maker. Do you have any last words of advice for trainees that are looking forward to their careers? And, it's obviously a big transition for us going into becoming junior faculty, then eventually getting labs, trying to grow into becoming our own person, our own surgeon. What advice would you have for those of us that are coming out of training and figuring out what it means to become an academic surgeon?
I think a little bit of soul searching, what means the most to you and what do you enjoy? If those questions can be answered, you can start to structure your career around developing those things. You can't do everything, even though you may enjoy doing everything. You can try and find that niche. If education and teaching is really where you find the greatest joy, then start structuring your career around how you can develop your research around that, your uh, whether it's a program director or an APD or running the sim lab, something in this direction as your focus. I think the other advice I have is to try and combine your interests in academics and in research with your clinical interests. When these two things are aligned, you really become a voice for that process, whether it's a disease process or a technique or a program or an educational curriculum, whatever that thing is, you can be the person that people turn to as a voice of truth around that rubric. So I see sometimes people have research directions that are very different than their clinical interests. And I think that's when it gets hard to juggle all the time management issues that you were bringing up. Because as you get more and more successful, people will ask you to do more and more and eventually do some administration. And time management will then become even more important.
Well, thank you so much, Dr. Maker. We really appreciate your time. This was awesome. We'll probably have you